My name is Ayra-Soto, and this is my periodontal assessment project for advanced clinical procedures. My patient's name is Mindy Morrison. She's a 68-year-old non-Hispanic Caucasian who has hyperthyroidism. During the medical history, she told me that she was embarrassed. She let herself go after her husband had died 10 years ago. This led to her staying home majority of her days, and she has developed a drinking habit. Since she doesn't have children, she lost all motivation to care for herself. She rarely brushed her teeth, but her oral health has deteriorated so much she doesn't know what to do. But even before then, she didn't feel confident with her smile because growing up, brushing and flossing or even dental visits weren't important to her family. So Mindy currently takes methimazole tapazole for her hyperthyroidism. She is prescribed 10 milligrams by mouth every 12 hours. She has an increased risk of drowsiness. She has a potential to have a lower white blood cell count, which leads to infections and an increased chance of bleeding. Due to this, I had to check with her primary physician before any dental treatment. A couple contraindications is a sensitivity to this drug and breastfeeding women. A patient can develop an abnormal taste and salivary gland swellings. Due to her being postmenopausal and being having hyperthyroidism, she has developed osteoporosis and takes alendronate Fosamax. She's prescribed 10 milligrams daily by mouth. Due to this, it can cause gastrointestinal upset, so I needed to be aware of any needed bathroom breaks. She also could develop headaches, so a lower light is better. I did offer a pillow since she could have muscle soreness, and I needed to be aware if she got dizzy, which could increase her risk of falling and fracturing something. Contraindication of this medication is if she had a history of hypersensitivity, hypocalcemia, any abnormalities of the esophagus, or an inability to stand or sit upright for at least 30 minutes. The biggest oral effect is osteonecrosis of the jaw. So here's my periodontal assessment. As you see, my patient has bleeding on probing and mobility on almost every tooth. The patient presents with generalized 3 to 5 millimeters on the anteriors with a localized 7 millimeter pocket on number 27, but in the posteriors, the patient has generalized 4 to 8 millimeter pockets. The patient has generalized recession involving furcations, and the clinical attachment level has decreased beyond 5 millimeters. For my findings, I classify the patient as having generalized stage 4 since her clinical attachment level is greater than 5 millimeters. Generally, her bone levels extend to or past the middle 1/3 of her roots, and she has actually lost 6 teeth from periodontitis. Because of the mobility, she has masticatory dysfunction and secondary occlusal trauma because of loss of attachment. When the patient was in my chair, she presented with heavy biofilm deposit that correlated with the health of her mouth. Due to her age, and she stating that she stopped caring for herself 10 years ago, I classified her as a grade B. While I was assessing the gingiva, these are my findings and what I documented. I will go over it on the next slide. The American Academy of Periodontology classification is the patient presents with 6 missing teeth due to periodontitis. She presents with masticatory dysfunction and secondary occlusal trauma. The patient presents with generalized 4 to 8 millimeter clinical attachment level loss with localized 10 to 12 millimeter clinical attachment level loss, having class 3 and exposing class 4 furcations. Radiographs show bone level loss extending beyond middle third of root. The patient has lost clinical attachment levels by 2 millimeters in the past 10 years. The patient presents with tenacious calculus and heavy deposit. The gingival description is the gingival color presents as dark red. The distribution is on the free gingiva and attached gingiva. This condition is generalized with localized moderate diffused bright red on specific marginal areas of the maxillary arch. The gingival contour shows signs of generalized rolled, festooned, and receding margins that is severe in severity. The papilla is generalized blunted with localized crater that is moderate in severity. Gingival consistency shows signs of severe swollen on attached gingiva with localized moderate soft or spongy consistency on the free gingiva of number 23 through 25 and number 6. The gingival texture alternates between generalized moderate loss of stippling on attached gingiva and generalized moderate areas of shiny surfaces on the free gingiva. Here's an interpretation of an FMX to justify my classification. Now, I just want to point out that there are more areas in the mouth that show the same signs of perio, but I just wanted to highlight what they are. For instance, there's a horizontal bone loss throughout the mouth, but I only highlighted it in the anteriors. So there's signs of erosion caused by loss of density. The bone levels have decreased past the middle third of the root, exposing furcations, but I really wanted to point out that class 4 furcation. On top of the horizontal bone loss, there is also vertical loss. There is secondary occlusal trauma resulting in tipping and movement of the teeth. Patient presents with generalized receding gingiva, exposing a class 4 furcation on the maxillary left posterior. The gingival color presents as dark red distribution on the free gingiva and attached gingiva. The condition is generalized with localized moderate diffuse bright red on specific marginal areas of the maxillary arch. Severe generalized rolled festoon margins with generalized blunted papilla. Presents generalized swollen with localized soft or spongy consistency. The gingival texture alternates between generalized moderate loss of stippling on attached gingiva and generalized moderate areas of shiny surfaces on free gingiva. So Mindy's prognosis is poor. She will continue to deteriorate without any intervention. She has severe bone loss, causing mobility that may need to be extracted. Patient shows sign of being uneducated to properly clean her mouth. Her outcome will be tooth loss and more bone loss. So some short-term goals for the patient is I want her to understand proper oral hygiene instructions. So that's brushing, flossing, just kind of the basics. As a clinician, I want to eliminate the gingivitis, arrest the progression of the periodontal disease, I want to educate the patient on the importance of oral hygiene, and motivate and encourage the patient to continue restoring her oral health. Some long-term goals, I want Mindy to understand the importance of maintaining routine cleanings. I want her to develop beneficial oral hygiene habits and reduce her plaque index by improving brushing techniques and flossing. As a clinician, I want to reduce her bleeding on probing. I want to reduce the inflammation and restore oral health to pre-disease status. So some modifiable risk factors that we can work on is her plaque, the bleeding, gingivitis, some calculus, her alcohol consumption, the frequency to the dental office, and the restoration to her dental decay. Some risk factors that we cannot change, unfortunately, is her osteoporosis, her hyperthyroidism, her mobility, and her bone loss. These are the treatment codes I selected for my patient. I will be going over these within the next couple of slides. Initially, my patient's chief complaint was pain in her jaw/mandible posterior region. Due to her coming in with a specific condition, I used code D0140. Unfortunately, with state of her oral health, she needed a comprehensive exam but couldn't be done with the amount of heavy biofilm. Therefore, I did a D4355 preliminary debridement. For her second appointment, she came back for a D0150 comprehensive initial evaluation. We were able to determine the best course of treatment for her. I performed a D1330 to get the patient to understand oral hygiene instructions. So her last appointment, it was determined she needed a full mouth SRP. So for her third appointment, we did the right side of her maxillary and mandibular arches. I used a code D4341 for this procedure since she has more than 4 teeth in each quadrant. Afterwards, on both quadrants, I did a gingival irrigation to remove any leftover debris. For appointment 4, we did the same exact thing, but on the left side of her mouth. Appointment 5 is the 6-week evaluation appointment. I performed a D4910 periodontal maintenance procedure. I placed monocycline in some pockets, but not all, to suppress pathogenic bacteria in those pockets. This procedure uses the code D4381 for each tooth that a resin was placed. These are the 5 appointments Mindy needed to get her started on recovering her oral health. She is placed on a 3-month recall. I would like to state that due to her severity, the mobility, and even the medications, she was referred out to an oral surgeon and a periodontist. These are the instruments that I had used. I started with ultrasonic tips because they are great for clearing deposits in deeper pockets. The standards can be used all throughout the mouth, but the site-specific tips have better angulation for adaptation. The left and right tips are great for adapting in root concavities, furcations, and just around the individual root. I then used the scalers for supragingival. I use the Nevi 1 for the anteriors. The disc end is great for heavy calculus removal on the lingual surfaces. The Nevi 4 has an increased shank rigidity, which is good for removal of burnished tenacious calculus with less effort and fatigue. My Gracies that I used were the 5.6, 15, 16, 17, 18, and the Mini 5.12. I used the Mini 5 to reach deep pockets of the anteriors and complex furcations. It allows a better adaptation around the root. The 15-16 has an increased angle, providing a superior adaptation. The 17-18 has a 90-degree angle that allows reach and better adaptation to posterior teeth. These are the home care recommendations I advise Mindy to use. She should use a prescription strength fluoride toothpaste called Clinpro 5000. This will help prevent root decay. I advise using a rubber tip stimulator for blood flow in the gingiva and the tongue cleaner to remove the bacteria on her tongue. She should use an electric toothbrush like Oral-B since the head is small and round, and brush for 2 minutes twice a day. I advise she shouldn't apply heavy pressure or vigorously brush back and forth so she doesn't cause more abrasion to her enamel and exposed roots. The toothpaste I recommended was the Clinpro 5000 or Parodontax. Parodontax has stannous fluoride, which is beneficial to reducing bleeding gums. Flossing should be done with a super floss or traditional floss, but because of her recession, it may be difficult, so I would advise that she invest in a water pick. She could use mouth rinses of her liking, but I did recommend Paradex, a zero alcohol Listerine, or ACT. Some products I warned her to avoid were mouth rinses with alcohol or products with essential oils if she ever does develop burning mouth syndrome. That is a possibility with hyperthyroidism. She should avoid whitening products to not cause hypersensitivity, and she should avoid hard bristle toothbrushes as those will be too harsh and abrasive for her teeth. With Mindy's hyperthyroidism and alcohol use, her oral health could benefit if she adds and restricts her diet. Most important is for her to have a low iodine diet. Foods she should eat on a daily basis are like egg whites, fresh fruit, oats, and potatoes. Low levels of iron are linked to hyperthyroidism, so she needs to be sure to eat foods like lentils, poultry, or whole grains. Also, healthy fats help balance thyroid hormones. She should limit alcohol, gluten, soy, and caffeine in her diet to avoid inflammation, interference with treatment, or exacerbate hyperthyroidism symptoms. She needs to avoid a diet with excess iodine, so she should stay away from iodized salts, fish, and dairy. Nitrates are a chemical that may cause her thyroid to actually absorb too much iodine. So foods like processed meats, celery, lettuce, carrots, cucumbers, or even spinach should be avoided. Orange juice, coffee, and mineral waters could reduce the absorption of alendronate, so those should be avoided too. Hyperthyroidism has caused osteoporosis for Mindy. She needs to make sure that she is eating a diet high in vitamin D and calcium. She should consult with her primary about taking those supplements if it's inadequate.